Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and today we are going to dive into another fellowship snippet. Good news before we start. Critical Care Education website for fellowship and primary prepcast is back running, so you can access all the old show notes for fellowship prepcast on the website now. So, thanks, Maddie. So let's dive into today's case. So a 74-year-old obese female patient with type 2 diabetes is transferred to your ICU from a district hospital with a confirmed diagnosis of ascending cholangitis. Ultrasound has confirmed an impacted gallstone in the common bile duct. Her current vital signs include temperature of 34.5 degrees Celsius, cold clammy peripheries, capillary fill time of more than 4 seconds, heart rate of 130 beats per minute sinus, blood pressure of 90 or 50 millimeters of mercury. She's currently maintaining SATs of 100% on 4-liter oxygen via nasal prong. On clinical examination, she is confused and her GCS is recorded to be 13. She has normal heart sounds with no murmurs. She has got some inspiratory crepitations basally with no added wheeze or bronchial breathing. On clinical examination, the abdomen seems to be soft with some right hypochondrial tenderness. However, there is no rebound tenderness or guarding. IDC has been inserted. However, urine output seems to be only 20 to 30 mils per hour at the moment. So can you please outline your initial management of this patient?
Sure. So this lady has severe ascending cholangitis with signs of shock and multi-organ impairment. My initial management would involve stabilization, specific management, including source control, and then overall supportive management. So from a stabilization perspective, I want to ensure she had adequate monitoring and access. So we don't know from the district hospital what their facilities were, but I'd like at least 2 large bore cannulas and an art line in situ whilst getting further access. And she will need a central line, if not already present, and to take blood cultures with the same. From a hemodynamic perspective, I'd assess her fluid PAP status. Currently, given the stem, she does have signs of potential fluid overload given her bivasal creps. I will start vasopressors preferentially given this and examine the patient and do a bedside echo for a quick assessment of her cardiac function, given her age, her potential septic cardiomyopathy, and an ECG to exclude ischemia. I'd be starting peripheral vasopressors until a central line is in situ and then noradrenaline aiming a MAP of 65, and then would be an ongoing assessment of the impact on her organ function by evaluating evidence of end organ function like her mentation, hemodynamics, urine output, and acid-base status on an ABG, especially her lactate. The stabilization would also involve supporting her respiratory function, so titrating supplemental oxygen to SATs of 92%, and a chest X-ray to evaluate for cause of hypoxia, so effusions or infiltrate. Currently on her stem, there's no urgent indication for further respiratory support or mechanical ventilation, but she is at high risk of deterioration and may need this of worsening confusion, increased work of breathing, or hypoxia. And she'll most likely need intubation for source control. And I'd be warming the patient with a bear hug aiming a temperature of 36 degrees. From a specific management perspective, I think the priority is source control. So because contacting gastroenterology and anaesthetics regarding an urgent ERCP or plus minus a sphincterotomy for relief of the biliary obstruction. There are other potential options for source control, including percutaneous transhepatic cholangiography and biliary drainage, but or surgical decompression, but this will depend on the patient and her other comorbidities and the anatomy. I'd ensure from a preparation for the procedure that a grip and hold is taken, and I'd be reviewing her medications for things that might complicate this procedure, such as antiplatelet and anticoagulants. And I'd still be starting, if it hasn't already been done, broad spectrum antimicrobials with tazocin, 4.5 grams 6 hourly, unless there's renal impairment, which will require dose adjustment. So she does potentially have a degree of renal impairment, given that she's been oliguric after IBC insertion. Also, the antibodies would need to be rationalised depending on the results of cultures, if any are available from the district hospital. And then finally, from a supportive management perspective, be supporting her organs from a renal perspective, monitoring her urine output and renal function, avoiding any further nephrotoxins, checking the catheter patency, and then dialysis if there's refractory hyperkalemia, acidosis, or for fluid removal, depending on her trajectory. From a hepatic perspective, checking her LFTs and coags, given the potential for multi-organ failure and with this sepsis. and for putting her just on mechanical DVT prophylaxis for now. From an analgesia perspective, IV paracetamol initially and IV opiates, so I'd just be giving fentanyl boluses at 10 mics initially if there's ongoing pain. She might not be suitable currently for a PCA given her confusion. And then sugar control, I'd be checking her sugar and ketones given her history of type 2 diabetes, and starting an insulin infusion preferentially given she's likely to be nil by mouth for the pathology and the procedure. And she, in terms of her logistics and disposition, she'll need ICU. She'll need to go to theatre or to interventional radiology, depending on what the procedure is, but ensure that she has ongoing support in the ICU and contact her family.
Thanks, Maddie. So what are the organisms that can cause acute biliary sepsis?
So these can be divided into gram-negative, gram-positive, and anaerobes. Gram-negative is the most common by far. So these organisms could be E. coli, Klebsiella, Enterobacter species, or Pseudomonas. Gram-positive organisms can also cause biliary sepsis, and these include Enterococcus and Streptococcus. And finally, they're anaerobic organisms such as Bacteroides and Clostridium perfringens can cause biliary sepsis, but these are less common.
Thank you. And how is the severity of acute cholangitis classified?
So there's the Tokyo 18 guidelines, which classify acute cholangitis into 3 grades. So grade 1 is mild, grade 2 is moderate, and grade 3 is severe. Interestingly, grade 1 is just classified as acute cholangitis, which doesn't meet the criteria for grade 2 or grade 3. So it's almost like a rule out or an exclusion label. A grade 2 cholangitis is acute cholangitis associated with any 2 of the following. So leukocytosis or a leukopenia, so white cell count of greater than 12 or less than 4, a temperature of 39 degrees, age of 75 or more, a total bilirubin of 85.5 micromoles a litre or more, or hypoalbuminemia. And grade 3 is acute cholangitis associated with onset of at least one organ dysfunction. So that includes hypotension requiring any dose of noradrenaline, any disturbance of consciousness, reduced PF ratio, oliguria or a raised creatinine, a raised INR, or platelets less than 100. So for this lady, she would be a severe or grade 3 acute cholangitis. The Tokyo guidelines also put in recommendations about management depending on the severity of the cholangitis. So they recommend biliary decompression or urgent biliary drainage for patients with severe cholangitis and early drainage for those with moderate cholangitis. But the exact time frame varies depending on the sources in terms of what is classified as urgent versus early. But a lot of the guidelines and sources recommend decompression within 24 hours for those with severe cholangitis. And the Tokyo guidelines are actually pretty useful resource and interesting read. So they're also in the show note, a link to them.
Thanks, Buddy. That's very educating for me as well. I did not know about the Tokyo 18 guideline, what these 8 guidelines are, but that's very informative. Thank you. So this question often comes at the bedside discussions about these patients. Often the question is asked, the gallbladder is distended, how should we drain it? And one option is either you put a biliary stent via endoscopic procedure like ERCP, or you can do a percutaneous biliary decompression using your intervention radiology services. So can you please outline the advantages and disadvantages of endoscopic versus percutaneous biliary decompression or drainage?
Yeah, so I thought this was interesting to think about because I don't know, when I've seen patients with biliary sepsis, they often come after the procedure. So we don't really get to see the decision making for which technique is there. But in terms of endoscopic technique, it's done through an ERCP. So a duodenal scope is inserted and this visualizes the bile duct. A catheter is then inserted into the biliary tract and contrast dye injected to evaluate the stone and the anatomy. And then the stone is extracted with a balloon extractor catheter or with a wire basket. Patients undergoing this often require a biliary sphincterotomy for removal of the stone if the stone is impacted or it's very large. And a stent might be also inserted. And an EUS guided biliary drainage can also be used in terms of endoscopic techniques rather than an ERCP. The advantages are that from an ERCP perspective is it's associated with lower mortality and morbidity compared to surgical decompression. And it can be used for diagnosis, not just for management. And it's considered the gold standard currently for treatment of ascending cholangitis. From an EUS perspective, so without the ERCP, it's got a similar technical success rate to ERCP, but at less risk of pancreatitis. And from a disadvantage perspective, ERCP, we know we've seen those patients with pancreatitis, they also, there's a risk of bleeding and all the anaesthetic risk, as it often requires GA or sedation. The positioning is difficult. So the patient is required to be semi-prone, so it's more difficult to get lines, endotracheal tubes in. It uses a lot of radiation and it requires specialised access to facilities and a gastroenterologist. Finally, it may not be technically feasible. So if those who have post-Whipples, who've had a Roux-en-Y procedural anatomy, or if you just have technical difficulties and are unable to pass an endoscope. From an EUS perspective, the disadvantage mainly is less common compared to ERCP, so it requires more expertise and facilities. From a percutaneous perspective, so the percutaneous transhepatic cholangiography, or a PTC, involves a transhepatic insertion of a needle into the bile duct. The contrast is injected and a drainage cannula is often placed. So this is called percutaneous transhepatic biliary drainage. You could also do alternatively a percutaneous cholecystostomy, where a needle is placed under ultrasound or fluoroscopic guidance into the gallbladder, a wire, and then a catheter is placed, which decompresses the gallbladder. So from a percutaneous advantages perspective, it's performed when endoscopic drainage is unavailable, unsuitable, or unsuccessful, and it can be done under local anaesthetic. And the positioning is often less tricky compared to an ERCP. However, it's more invasive compared to endoscopic drainage. You've got its own set of complications, including bleeding, bile leak, increased pain, catheter migration. And then from a percutaneous cholecystostomy perspective, it's less commonly performed for cholangitis. Then the catheter can also migrate and it requires an intact gallbladder, which not everyone has.
Yeah, thanks, Mani. So often I look at the way of this kind of process. Obviously, it depends on which specialty is primarily involved in managing these complications. But if there is a common bile duct stone and need stone removal or sphincterotomy and stent insertion at the same time, usually it's ERCP is preferred. But if it's just a distended gallbladder with some cholecystitis features, and in that kind of cases, probably if the surgeons want to do cholecystectomy at a later date and they just want to give antibiotics, but at the same time allow the source control, then usually go via percutaneous or interventional radiology route. I think it is important to know the complication of each procedure and how that can impact our ICU management, I guess. So that's the end of our today's snippet. We'll be back with another snippet in a few weeks' time. Till then, goodbye and have a nice time.
Thanks for listening and see you next time.